Thank you for logging on to view the Personality Disorders webinar. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website, www.nahatica.org. After completing this webinar, please upload and complete the quiz if you are interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation or on our website, nahatica.org, or you can email the Training Institute at nahatica.org. You can email, mail, or fax the completed quiz. Contact information is on the quiz itself. If you are a member of the Nahatica or NADAC, the certificate for the webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar, if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as the NBCC. If you have any trouble viewing the webinar, audio problems, or have technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to traininginstitute@nahatica.org. You can find and upload these introduction slides in the file pod to the right of your screen. And with that, I am going to turn you over to Joe.
Very good, thank you. So today, we're looking at borderline and antisocial personality disorders, specifically those two disorders. The primary reason is quite simply that these are the disorders you're most likely to encounter typically in residential settings, but also in just about any outpatient setting. You're also going to find they're the most challenging in terms of treating. The fact is that personality disorders are somewhat common. We're looking at National Institute of Mental Health saying somewhere on the orders of 9% of the U.S. population, about 1 in 11, meet the criteria. Now that's under DSM-4 criteria. The DSM-5 data haven't been collected, but the criteria are the same. Statistics being what they are, a few points, a few percentage points up or down, we're still looking at a sizable part of the U.S. population. Other surveys have estimated the percentage typically between 9% and a bit higher. You'll notice that you've got narcissism at the top of the list, 2.2% of the population. That is very likely accurate. You can see that in the disorders that you're probably encountering with clients now. Typically, if you're dealing with substance abusing populations, you'll see quite a bit of that. There's obviously a difference between traits and having the full-blown diagnosable disorder. You really want to go into the DSM-5. If you're still using the 4, switch to the 5. Again, the criteria are about the same. Again, narcissism more common, but you're going to see borderline and antisocial our focus today. I will be touching base on the other personality disorders just briefly in order to round this out. But those are the things to really be concerned and focused on. You're going to see those people typically are the ones mandated to treatment. No big surprises there. These are the people that are seeing you. They may not necessarily want to be seeing you. It could be because of legal involvement, because family or friends or their job are pressuring them into seeing you. In the general population, you're going to see substance abuse. Now, dual diagnosis is quite common. We all know that. Among substance abusers, about 22% of the American population are abusing substances. Pot is obviously brings those numbers rather high. There's always the question of whether or not it's legal, whether or not it's as safe as alcohol. We're not really addressing that at this point. Merely the fact that with any DSM diagnosis, and of course we're looking at the 4, but with any DSM diagnosis of an Axis 1 disorder, 67% are also going to be co-occurring substance users. What you often see are alcohol, pot, Depending on the area you live, you'll see some variations. In Connecticut, you might see a decent amount of PCP abuse. That's going down in other parts of the country. You'll see the alcohol, pot, cocaine are typically there. You also need to look at the prescribable medications. Typically what you're going to be seeing abused are anti-anxiety meds. Doesn't mean that you don't see all the others, but those seem to be rather common with personality disorders. Generally the reason is the anxiety. They do not feel good. They are rather anxious. We're looking at the most common psychiatric disorder found among substance abusers. Again, 50 to 75%. That's a pretty high number. If you're dealing with somebody with a substance abuse disorder, you probably want to be assessing their personality issues. Just because they may not meet the full criteria of a personality disorder doesn't mean they may not have the traits. And of course, if you're dealing with somebody who's in dire straits in terms of their substance use, if they're actively abusing, you really can't make a clear diagnosis. You can begin to look at things. You can document the traits. If you have done some really serious assessment and you know about their pre-substance abuse level of functioning, you're probably going to have family or friends or the doctor that they dealt with before say, well, this is what I saw before they were abusing cocaine. Now you're talking. Now you're getting information that you can work with. You know about their pre-level of functioning. That means you may be able to make the diagnosis of a personality disorder, even if they're still abusing alcohol or drugs. Again, you're looking at just some broad statistics. Borderline personality disorder and antisocial personality disorder have a much higher rate of substance abuse. You're looking at correspondingly 57% for borderline and antisocial 27%. And you just are going to see this. They co-occur. You're going to have to deal with that. If you do not have expertise in dealing with substance abuse, get somebody on your team who does. If you're a substance abuse clinician and you're not experienced with personality disorders, work with a clinician, co-work with a clinician who is familiar with those things. These co-occurrences are going to interfere with your diagnosis. They're going to interfere with treatment. You're looking at antisocial personality and borderline personality disorder being the prime substance abusers. Narcissism, yes, you will see that. But for different reasons, and typically, again, we're not specifically focusing on narcissism today, or paranoid or histrionic, etc. Among the spectrum of personality disorders, you're seeing characteristics of all of these disorders in 3 distinct clusters. It doesn't necessarily mean that there is the same underlying process causing, for example, a person to be paranoid, personality disorder, schizoid, or schizotypal. But the symptoms make them cluster together. These clusters have not been rigorously proven. They seem to hold together, and it is a decent way and a helpful way of looking at the disorders. You do see symptoms cluster together. So you will see an antisocial have some, for example, of the same traits as a borderline. You'll see borderline and histrionic have some of the same traits, for example, as narcissism. You don't necessarily see an avoidant personality disorder having similar or overlapping traits with, for example, a paranoid or an antisocial. Again, similarities, but the clusters seem to hold together. And the prevalence in the US population, again, 9.1, the reason those stats don't look like they all add up correctly is because there will be overlaps. A person can have more than one diagnosis of a personality disorder. You can be both antisocial and, for example, histrionic, or in this case, antisocial and borderline. Now, you're going to hear people, and you hear this from clients, I hear from clinicians as well, and they'll say, oh, I have an addictive personality. There is no such diagnosis. You can go into the DSM from beginning to end. It is not an actual psychological diagnosis. It's actually not a very helpful term. What they're really saying is that they have obsessions or compulsions, or that they're drifting from one drug to another. There's no such thing as an addictive personality. There are common personality traits: seeking excitement, impulsivity, feeling alienated, etc. You're going to see a lot of this hold together. These are common among all the behaviors of addiction, and that's why sometimes a person will say, well, I have an addictive personality, and what they're actually saying is, well, I have traits that hold together. As a clinician, you'll see this, and you'll be able to identify it, possibly clarify it with the person. It's your judgment as to whether or not you want to explain to them that they're not an addictive personality, that maybe they just have some traits in common. Helpful to know. Also, it's rather important when you're documenting. You can't say that they have something that doesn't exist. Now, these traits, personality traits, those things tend to develop early in your growth. You're looking at personality developing from an early age. You'll see parents of newborns talking about their personality. I actually think they're rather accurate. They know what they're seeing. They are seeing what the person is at that age, maybe even seeing if, for example, they're afraid of strangers, they're shy, they're avoidant. That's the sort of thing that might start in early childhood and run through the rest of your life. The personality traits of addiction are a little harder to define. You have to know when the person has begun abusing. You have to know, for example, in your assessment, when did you start? When did you start abusing drugs? You need to know that, because if they started abusing alcohol or cocaine and it was during their teenage years, be aware that had a big effect on the development of their personality. It also is very possibly shaping your personality for the rest of their life. If they are having difficulty with anxiety and, for example, using alcohol to mask it, well, that's one of the reasons why it could become habitual. They started early, their brain was still developing. Personality, if we're just seeing it distinct from substance abuse issues, develops slowly, usually in the first 20 years of life. By about age 25, you're kind of who you're going to be. If you're normal, if you're healthy is a better term to use rather than normal. If they have a healthy personality, they can cope with stresses, they'll have ups and downs, they'll form relationships, they'll be able to get along with family, friends, and coworkers. A person with a disordered personality, they may take a trait, for example, histrionic. We're all capable of having a fit, of having emotional swings, highs and lows. With a person with a personality disorder, that trait is carried to extreme. It is rigid. It is possibly their primary way of dealing with reality and interacting with people. It becomes a disordered picture, so to speak, of who they are. A personality disorder is pretty easy to identify once you really sit down and assess and talk and process with the person. These are things that they're deeply ingrained, they're inflexible. You talk to their family, you talk to them, you talk to their friends, and this is the way they are. This is the way they always are. It's not just because they're getting over a drug. It's not just because their husband or wife left them. This is the way that they deal with reality. It impairs their functioning. They typically are behaviors that don't distress the person directly. If they're a narcissist, they think everybody else has the problem. They don't see it in themselves. If they are histrionic, they think everybody else should be reacting just as upset as they are, when in fact it's really, really out of the norm. The most distressing this is to the people around them. Husbands, wives, children, family, friends, coworkers. It's not distressing per se, to the person with the disorder. They're distressed about how everyone is acting or not acting around them. The distress, the reason a person with a personality disorder typically comes to us, if they're not referred by the legal system or being pressured into it by friends and family, it's very common that you're not going to see these people. They may see you because they have a problem with alcohol, but in fact, they may be a borderline. They're using the alcohol possibly to mask the symptoms of their distress. You're processing their substance abuse issues with them. You begin to realize, oh, there's something underlying this. Again, defining characteristic in big, bold letters. They tend to be inflexible, rigid, and unable to respond to the changes and demands of life. They think everything for them is normal and the way things are supposed to be. Everybody around them says, wow, you really need to change how you handle this stuff, how you handle stress, how you handle what you do. These disorders must meet criteria. You can see traits. You'll see quirkiness. You may see somebody in early recovery who looks histrionic or borderline. But these must be deeply ingrained patterns, inflexible. They also typically must be causing enough distress that it's impairing their function. The person needs to feel that there's a problem. That can be problematic when you're dealing with a personality disorder and they think it's everybody else with the problem. I think you're beginning to see that there's an issue here with how can you diagnose it if they don't think that there's an issue. Well, you can diagnose it, but you really do need to identify that the distress the person is feeling is rooted in their behaviors. That's how you make that diagnosis. It's less obvious to the person. These disorders don't necessarily fade or go away, but you will see them moderate. A good example is that an antisocial personality disorder, typically by late 30s, mid 40s, the 50s, the person just isn't engaging in as many things that get them arrested or get them in trouble or get them in fights. One way of looking at it is that they burn out on the issues. They can't maintain the lifestyle. They get tired of being put in jail. They begin to realize if they work their job and don't steal from the boss, they can keep the job. Outside influences, the social environment around them, begins to curb those behaviors. Early childhood obviously has a huge effect on us. Now, it's very easy to say, well, they're this way because of how they were raised, or because mom or dad did this or that when they were 5 years old. It's very hard to make a real link and say, this caused that. It's not found in our field. You will see that this was a contributing factor. Genetics, for example, are a contributing factor. But a person does not become something because of their genes. It will push them in a certain direction. It may give them some hurdles that they have to overcome. For example, we know that it's very likely that alcoholism is something that is an inheritable trait. It doesn't mean that you're going to become alcoholic because your father was alcoholic. But it definitely is one of those red flags. Environmental factors, obviously, they have a huge effect. You may have been born with a tendency for heart attacks in the family. But if you don't overeat, if you exercise properly, if you never smoke, you may never activate those genetic predisposing factors. It might mean that you can live a perfectly healthy life if you take care of the stresses in your life. Personality disorders, they're in the DSM-5. They're categorized along 3 clusters. So you're seeing 10 formally identified personality disorders. There may be some other disorders out there, but these seem to be what we're finding. And the DSM-5, same as the DSM-4. You're seeing 3 clusters. Quite simply, and this is a simple descriptive. Cluster A, you're looking at the odd and eccentric behaviors. Cluster B, you're looking at the dramatic, emotional, erratic behaviors. That's where we were interested today. Cluster C, the anxious and fearful behaviors. Again, a personality disorder, you need to understand. This doesn't mean that they're broken. That doesn't mean that they're fatally flawed. It does mean clinicians tend to get concerned. Oh, I have somebody on my caseload who's a borderline. Well, okay, you could also have somebody on your caseload who has cancer. It doesn't mean you don't treat it. It doesn't mean it isn't treatable. It doesn't mean it's not addressable. These disorders are relatively common. You're going to find them in the broad range of the population. They respond to therapy. You just need to accept that, and that they might need a little bit different therapy or more therapy than other disorders. The healthy personality, let's start with the healthy one. They accurately interpret their environment. They're not overreacting. They're not too predisposed to see things incorrectly. They can appraise their own strengths and weaknesses, meaning they have good insight. They can get through the world. They make some mistakes, but not quite as many as somebody with a disorder of their personality. The inflexibility, again, that is the prime, clearest definition of a personality disorder. It leads to all the problems you can see: distress, dissatisfaction, failure. Even well-adjusted people can have issues. Let's be real. If you've ever fallen in love and then fallen out of love, you know that you can have some pretty wacky thoughts. You can have some distressing thoughts and distressing behaviors. Another very good example of that is that you may see somebody and you think that they have a personality disorder. In fact, they might. But what often is going on is that there's been some trauma in their life. They have responded to the trauma as best they can with whatever behaviors that they think are effective. Unfortunately, it looks like a personality disorder. Doesn't mean that it's not. I'm just saying, if they don't meet the criteria and you can identify that they in fact survived a horrible accident or combat, which we're seeing a lot of combat veterans come back, it may look like a personality disorder, but if you can clearly discover that before they went off to war, they behaved a certain way, they functioned well, they may have had a few quirks, but nothing that really brought them to the mental health system or caused them or their family distress. Now they've come back from war. They're histrionic. They are having trouble with all sorts of other issues. It might look like a personality disorder. In fact, you might be looking at an underlying trauma. Again, assessment, getting a good biopsychosocial is critical for determining what's going on. Once again, looking at the co-occurrence, and again, the focus on cluster B, borderline and antisocial personality disorders. They're the most common personality disorders associated with substance abuse. So again, you're going to get somebody come to see you. Maybe it's because they have an alcohol issue, maybe because they have an opiate issue. You get to know them, you get them or help them attain sobriety. They keep seeing you, and now you're beginning to see some other traits. Now, I'll tell you that in my experience in, for example, a residential setting, somebody in early recovery who has an antisocial personality disorder is going to manifest a lot of negative personality traits. They're going to get into arguments. They're going to be very non-receptive. As they get more sober, as their nervous system is calming down, as they're feeling a bit better, maybe they're on medication for anxiety or depression, those traits, those borderline personality disorder, or as I was saying, it was antisocial personality disorder traits, they may begin to fade a bit. You may still be able to diagnose that disorder. But in point of fact, if they're in a stable recovery, they may not look nearly as troubled. The underlying personality disorder is not being exacerbated by the pain of recovery. So if you've been able to build a relationship with them, you may be able to do some very effective work at that point. You've seen them through their early recovery. You've built some trust, built some connection. They want to keep working with you. This impulsivity hypothesis, why do people have personality disorders? We do see impulsivity is extremely common. They have a hard time resisting drugs and alcohol. They make poor decisions. They decide to jump into cars with their friends when they're drinking or drugging. They decide to hang out with somebody when they shouldn't. They decide to go places that they shouldn't be. They walk around with money in their pocket. They impulsively spend it. It's very difficult for people with impulse control issues to avoid drugs and alcohol. That's it, quite simply. So antisocial personality, is it because the person is impulsive and they can't resist the drugs and alcohol? Maybe impulsivity is the reason that they actually have the disorder. There's a common theory, and it's absolutely justifiable, that if a person has a mood disorder, they very often find it helpful to self-medicate. They're seeking a way to feel better. Unfortunately, illicit drugs and pharmaceutical medications sometimes work very quickly and very well. You can alleviate anxiety rather quickly with Xanax. You can do the same with many people with healthy doses of alcohol. It works quickly. It can be habitual because it works so well and so quickly. People with borderline personality disorder can take a long time to calm down. That's where a borderline can have these huge emotional upsets. And you're trying to help them with that, and the emotion's getting in the way of the therapy. Well, it's cases like that where it might look like a Xanax is appropriate. Maybe they've already been diagnosed and prescribed it. And all I can say is that you need to really monitor and properly help your clients regulate their medications if they're on medication, especially anything that is anti-anxiety. Those tend to be highly addictive, and the impulsivity and the self-medicating, bad combination, the immediate relief from their emotions means that they can easily become addicted. You're looking at people, this is a stimulation-seeking hypothesis. By the way, all these hypotheses taken together could explain a personality disorder. It could be that they have all of these things. They might be stimulus-seeking, impulsive, and having difficulty with anxiety. So the stimulus-seeking seems to make sense for the people with cluster B. They report, self-report. They get bored easily. They get bored easily, and they want to alleviate the boredom. Sometimes you'll hear clients describing an empty feeling inside. They have difficulty sometimes finding words for it. They'll fumble in sessions with you trying to describe how they feel. Oh, I'm just so bored, I'm so empty. It's often valuable to try and get them to find proper words, better words to describe how they feel. A client says they feel empty, you may think you know what they're saying. You get them to drill down, do it gently, do it almost like in a camaraderie kind of way. You know, oh, tell me a little bit more about that. Well, I'm not sure I understand what you mean. You may in fact find that they're not describing emptiness, they're describing anxiety, or maybe they're describing sadness or a grief or loss issue. Have them really describe what they mean, and that may be a way of finding out, well, your boredom. Oh, okay, your boredom is actually based on something else. Genetic studies. We know through the use of twin studies, and we're talking about many, many, many decades of twin studies, genetics contributes to just about everything. Contributing doesn't mean causing. It means it's one of the things that added to the weight of issues that lead to a disorder. Again, heart attacks may run in the family. It doesn't mean that you're going to have a heart attack. Cancer can run in families. Doesn't mean that you're going to get cancer. It's a contributing factor. Recently, we're finding out that twin studies may not have been nearly as accurate as we thought they were. That has to do with our new developments and understanding of epigenetics and how genes express themselves. Quite simply, identical twins do not have identical fingerprints. Well, they should, shouldn't they? Well, no. They develop with the original genes, but those genes express themselves in different ways. That's why they may be identical twins, but one, for example, might be a little taller, a little blonder, a little different. Genetic studies, again, they give us traits, they give us a direction to look, but they don't give us all the answers. You have a discussion question. Quite simply, we want you to look at what is the most common type of psychiatric disorder found among substance abusers. We're looking at bipolar disorder, schizophrenia, any personality disorder, or generalized anxiety disorder. And just discuss for a minute what is the most common type of psychiatric disorder that we're going to find among substance abusers. Give you about 10 seconds on that. Among substance abusers, the most common psychiatric disorder that will be diagnosable is any personality disorder. Quite simply, they go hand in hand. Again, one of the reasons may be the age of onset. Many people begin abusing drugs in their teens. Until you're age 25, you're still in a developmental stage. It's very common that your personality is going to be shaped and warped and affected by the fact that you're using hugely powerful chemicals. These chemicals, we talk about alcohol, we talk about pot as not that dangerous. It shapes personality. It adjusts and changes your brain. If you didn't get high or drunk, you couldn't give this stuff away for free. Nobody would touch it. We know these are powerful chemicals, and of course they affect our development. Again, genetic studies, we're looking at what might be a genetic basis for impulsivity and aggression. We know that from these studies, as you can see, University of California, we see a high prevalence of maltreatment by caregivers across all personality disorders. One of the key problems seems to be neglect. That doesn't mean it causes personality disorders. It is a major contributing factor. I could totally see that. If a person is a withdrawn personality, or if they have difficulty with boundaries and they're way too outgoing, picture a kid at a supermarket who's whining, screaming, totally out of control. If the parent isn't able to shape and adjust those behaviors into socially acceptable, healthy means, the child may grow up perpetuating those behaviors. So again, traits they were born with, which might not necessarily be negative, can become negative over time because they don't have a proper shaping influence from mom or dad or whatever parental figure, and it becomes their major number one way of dealing with the universe. The neurobiology, the actual neurochemistry of the brain, absolutely fascinating. There are huge developments going on in this field. You really need to do some self-study. There are any number of websites you can check. We know that when it comes to cluster B disorders, using PET scans, using computerized scans of the brain, we know that there is absolutely a correlation between people who have problems with their prefrontal cortices. You're looking at damage to the forebrain, the area of the brain that allows you to make good judgments. That may be that they were born that way. That may be that there was a developmental issue along the way. That may be neglect. We know that babies that are not nurtured will have enormous difficulty connecting with people later on. We've seen that with studies of children raised in orphanages in countries where the caregivers are overloaded, the children are given no attention at all. Again, that can change the development of the brain. Simple nurturing has an effect. So it doesn't seem to be much of a coincidence that there's a connection between the ability of people to control their emotions and make good choices if they have problems in the development of their forebrain. We see changes in the activity of serotonin. We see changes in the activity of most of the major neurotransmitters in terms of people with personality disorders. Serotonin seems to be the one of interest here. Not only does it lead to depression, it also leads to difficulty learning new things and able to focus your attention and concentration on one specific thing. We know from the actual testing of cerebrospinal fluid that there is an irregularity, there is an imbalance. Typically, there's a decreased level of serotonin. So let's just refocus here. We're looking, again, DSM-4-TR, the same as the DSM-5. You're dealing with adult diagnoses. The personality disorder is an adult diagnosis. You can diagnose it in children, but it must have been at least 1 year duration, and you don't diagnose antisocial personality disorder. That would be a conduct disorder diagnosis. Now, those clusters, the 10 disorders in 3 clusters, it's not consistently validated, but it is consistently accepted across the board in our field that this seems to be how these things cluster together. That's a categorical perspective. It doesn't mean that there is an underlying cause. That means that everything in cluster A is all caused by some particular part of the brain or the experience being disordered. In the DSM-5, you're looking at across all personality disorders, a general description. An enduring pattern of inner experience deviates markedly from culture. You do need to know something about your client's cultural background, especially if they were born and raised outside the United States. They may be from a culture that you're simply not familiar with. You're going to see Asian cultures. These are broad generalities. Asian cultures can be very family-centric to the point where the father figure in the family is the one who makes decisions. They may actually accompany the client to treatment. This is true of many other cultures as well. It can be culturally appropriate to be much more expressive of emotions. In other cultures, it's considered very inappropriate to be broadly expressing emotions. That will affect what your client looks like in front of you, so you do need to know a bit about that. Obviously, you can see and read the other characteristics in a personality disorder, and these must be met. If the client does not meet these particular conditions, you're really not looking at a personality disorder. You may be looking at personality disorder traits. You may be looking at somebody who's in the throes of their addiction or in early recovery. And so they just are presenting these particular traits. Just for perspective's sake, in cluster A, you're looking at odd and eccentric behaviors, paranoia, taken to the point where it's actually part of their personality, not just something they're manifesting because they've been using a lot of substances and it's affected their ability to not be paranoid. A classic would be somebody who's abused a lot of cocaine will have paranoia. A schizoid personality disorder, really detached. That schism isn't within the mind, as in schizophrenia. It's within their social attachments and relationships. These are people that are just disconnected from family, friends, and society. Schizotypal, you're seeing real distortions and eccentric behaviors of their thoughts, distortions of their processing. They're going to have really odd and eccentric ideas. Very great difficulty in close relationships. They don't connect well. Cluster B, that's our focus. Antisocial, pretty easy to define, pretty easy to identify. The disregard for others, the violations of others' rights, going against the grain, being proud of fighting the man. I fought the law and the law won, to go back to songs of the era. These are people that break rules, think that that's okay, justify what they do. They don't have regard for others. In a pure antisocial personality, they can actually, there is some evidence and some data to say that they actually can't feel empathy for others. That's very likely true. Borderline, and again, these are the two we're focusing on. Here you're looking at instability in relationships. They will form lasting, gigantic, oh my God, this is my best friend, shortly after they meet somebody. Fall madly in love shortly after they meet somebody. No, it is not a lasting relationship. I love you, I love you, I love you, and then, oh, I hate you, I hate you, I hate you. And they will flip back and forth, back and forth, back and forth on this. They're highly impulsive. They'll call you on your home phone in the middle of the night. Oh, I just overdosed, but I think I'm okay. But I just want to talk to you for a while. This is a very problematic client. They are absolutely treatable. Unfortunately, sometimes people feel, oh my God, it's a borderline. Get them away from me. No, 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 no. You can connect with and treat a borderline, just as you can an antisocial. Histrionic, again, they fall into the same cluster, this excessive emotionality and attention seeking. Pretty easy to identify. They walk into the party, they must become the life of the party. But it's not because they want it or need it. It's because their emotions are always out of whack. They are attention seeking, but with a narcissist, it's all about me, me, me. With a histrionic, it's all about everything. The narcissist is pretty easy to identify. You'll see them in the news, you'll see them on TV, some of the rich and famous. This massive need for it to be all about me. And they won't state it that way. They'll simply say things that draw massive attention to themselves. They will say things that draw positive or negative attention. They honestly don't care. But ultimately, they absolutely need this connection, this need for admiration. A serious lack of empathy. They really do not connect and work well with others. So with antisocial, here's your characteristics. You're looking at a pattern of behavior since the age of 15. Now, yes, it is age 15. You can think of that as hard and fast. The reality is you're not going to see somebody with an antisocial disorder who has not had these issues for a long period of time. It used to be that they had to be diagnosed with conduct disorder before age 15. We now know they just need to have evidence of it. You have to be in to see it. These are the people, the classic antisocial, sociopathic, psychopathic character. You'll see them in Hollywood movies, TV shows. You might think Hollywood is well, crazy. Unfortunately, Hollywood and the writers of popular media, as in TV shows, they never get it right. They'll give you the Hannibal Lecters. That's pretty darn rare. What you're really getting is the classic person that you see in treatment who has been breaking the law, getting in trouble. They're not cold and calculating. They're reckless. They're impulsive. The lack of remorse. They only need 3 of these bullet-pointed characteristics of 1 through 7. They don't have to have every single one of them. They may not look like they have all 3, but if you drill down far enough and you can say, yeah, it looks like they've got it, yes, you've got an antisocial personality. Obviously, the rule out would be if they have schizophrenia, if they have bipolar, which means they're losing touch with reality, they're doing things that are just like completely unhealthy. No, you're not making this diagnosis. You need to figure out what's going on with schizophrenia or the bipolar. The borderline, the defining characteristic, the thing that you're going to see is this impulsiveness. They're going to do things that you look at them and go, you did what? These are frantic efforts to feel connected, to not feel empty, to feel some sense of stability, when in fact they're doing these incredibly unstable things. Connecting to people, falling madly in love, falling madly out of love, making enemies at the drop of a hat. Impulsivity. Again, you're going to see that again and again and again. They often, not always, but often, will be doing some sort of suicidal gesture. These are where you're going to find the cutters, the people that burn themselves. Typically it's cutting, though. That seems to be very common. They will get lots of tattoos at the drop of a hat. Tattoos are perfectly normal and acceptable in society. These will be reckless gestures that will, along with all these other things, these feelings of loneliness or some sort of severe dissociative symptoms are the worst case scenarios. Those are the defining characteristics. You put all these things together, you've got a borderline. These people have a suicide rate of about 10%. Successful suicide rate of about 10%. Those aren't attempts. This is a very serious disorder. It needs to be treated seriously, and it does respond to treatment. they may need more hand-holding, more connection to the clinician than another person, but they do respond to therapy. So, simple facts. You're looking at how many people in the mental health system. You're looking at how many in the outpatient system. The suicide rate. Very sad statistics here. Many of the core traits have neurobiological underpinnings. You can look at the human brain and you can say, hey, I think I know where that's coming from. You're looking at an overall incidence in the general population of about 2% for borderline. It's far more common than Alzheimer's and schizophrenia. However, you have to remember, giving somebody a diagnosis of borderline is like a giant red flag for many in our field. So clinicians might be reluctant to put that on the person's chart. It's also sometimes a challenge to get insurance companies to understand and to pay for treatment. The other problem is you may be working outside the scope of your training. A person who is licensed as an alcohol and substance abuse counselor may be thoroughly competent and able to make this diagnosis, but if it's not in their core training, if it's not part of their licensure, you really shouldn't be making that diagnosis. So again, people that we see because they were mandated to treatment because they have these issues or these disorders, doesn't necessarily mean you can make that diagnosis. You can indicate your concerns and considerations. You want to refer them to somebody that can make that diagnosis. Borderlines, you're looking at very unhappy people. They go through very big highs, very big lows. A lot of depression, massive. So you're looking at people with difficulty controlling their emotions. Many of them report abuse. Now, abuse, when you look at the general population in the United States, sexual abuse is actually relatively common. You're looking at numbers between, I've seen statistics between roughly 20 and 30% of people report some sort of issue, contact, or abuse that can be absolutely categorized as sexual abuse. Now you look at the rest of the population, when you're looking at people with borderline, saying, okay, 40% to 71%, it is a contributing factor. Doesn't necessarily mean it is the cause. It is a contributing factor. You're seeing other important statistics about borderline personality disorder. Emotional regulation disorder. A genuine problem. Seems to be, as many of the things we're talking about, it's a combination of genetics and environment. That may lead, for example, to the neurological imbalances, serotonin, dopamine, that kind of imbalance in the brain. You're looking at these borderlines being more likely than those with other personality disorder types to use multiple substances, to be involved in the medical treatment system. Typically, it's because of the massive depressions, the suicidal or parasuicidal behavior. Parasuicidal refers to the cutting or burning or other kinds of behaviors. We're looking at also, for example, ritual scarification. People that will scar themselves in patterned ways because they like how it looks or because they want to fit into a gang or their peer groups. They will have repeated hospitalizations, back and forth. Imagine you have borderline personality disorder, you're being hospitalized, you don't understand why, you keep having these problems, nobody seems to understand you, they throw meds at you, they want to get you out of the hospital as fast as they can, no one's listening to you. This is going to lead to an exacerbation of all of the underlying issues. Proper treatment might lead to them feeling better and to those traits and characteristics not being exacerbated. They might actually feel better. They might actually get better. Just because they're borderline doesn't mean they can't be treated. Histrionic, we mention it because it does often make a very difficult differential diagnosis with borderline. The reason is those characteristics overlap. A borderline can look like a histrionic and vice versa. You'll see, if you look at the specific characteristics There are differences. The histrionic is going to be all about attention. They're all about focus. They're all about making themselves noted and notable. It's not quite the same as narcissism. It may look the same. You have to really dig down into the characteristics. Histrionic, they're always dramatic. They're flamboyant about it. Very difficult for them to control that aspect. Again, it's a personality disorder. It's part of who they are, personality. It's not something they can switch on or switch off. Now you begin to get into the idea, and again, we're looking at narcissism here, the grandiosity, the need for admiration, and the lack of empathy. It's that grandiosity and the need for admiration that sets it apart from histrionic, which is just emotions all over the place. They believe they deserve extra attention. They don't connect easily or well with others. There's a real lack of empathy. They really don't. Often, they really don't care how others feel. They think of that as a weakness if you try to explain it to them. The thing about a narcissist is this incredible shallowness, this incredible, actually, weakness in their personality. Imagine a very powerful, very gigantic, rich person constantly needing this attention, this grandiosity, the sense of self-importance. It's because of the underlying shallowness. There's so little genuine, solid ego there. They're envious of others. They want what others have. They want their attention. They want their money. They're boastful. They are fragile. A very fragile self-esteem. That's what sets it apart from these other personality disorders. That need for admiration, it's like a drug. But underlying it, they're incredibly weak, incredibly shallow. You see a lot less of that with the histrionic. They're simply all over the place because that's who they are. Cluster C we're mentioning in passing, and there's a reason for mentioning all these other disorders, is because a person can be diagnosed with more than one personality disorder. They do not have to be exclusively one or the other. They may be several. They may have traits of one overlapping another. Here you're looking at rigid and fearful. The cluster C people, for example, avoidant, highly socially inhibited, not just shy, wildly hypersensitive. Dependent, the classic image would be in the old TV show All in the Family, Archie Bunker's wife, Edith. Now, a brilliant actress, she brought to light this personality, not criticizing her or the character, but that character, especially early in the show's run, always there for the husband, always trying to deal with what he needed, running with his shoes, changing the food at the dinner table at the slightest whim of the husband. That would be the dependent personality disorder. Very clearly shown in that character. To their credit, the character grew as the show grew, but that early on was a very good definition of it. Obsessive compulsive, this isn't somebody that obsessively cleans, washes their hands, or obsessively does some ritual of turning the lights or the stove off and then having to check it 1,000 times. This is a pervasive obsessive compulsive across their entire life, everything about their life. They're preoccupied with orderliness, perfectionism, and control. Any one of the personality disorders can have traits of others. You need to be able to assess your clients. Everything goes on one axis. We no longer have 5-axis diagnoses. That is a thing of the past. These are adult diagnoses. You can see other important characteristics of the assessment. Some of these do tend to occur more in women and others more in men. This doesn't mean that males don't get borderline. Get implies that you can contract it. That's not the right way to put it. Quite simply, you can manifest or show these traits or these full-blown disorders. Doesn't matter if you're male or female. You do need to be careful about what substances they're using. If they're using substances that can cause psychosis, and they're looking like a cluster A personality disorder, well, you know what? They may not be. This is a rather intricate graph. I think the most important thing is to know that you can look this up. You can find this information. This is Tasman, Allen et al., 2008, in the Journal of Psychiatry. What they're showing is, if you look down the left column, pick a personality disorder, scan across to your right to look at a corresponding personality disorder, and you will see that there are a lot of co-occurrences. For example, an antisocial personality disorder, if you scan across and look for borderline up above, the BPD borderline, you're going to find out that there is a 59% co-occurrence of antisocial and borderline. One person can have another disorder. Some are far more likely than others. Again, these are both cluster B diagnoses, so it tends to show that the cluster holds together. Much less likely that they're, for example, going to be a schizoid. One person can have more than one disorder. In the assessment, you really need to look at their level of substance abuse. That's basic. We don't need to perseverate on that. We've gone over that quite a bit. You need to know what was the onset of the symptomology. Did it happen suddenly? A good example is maybe they had a car accident and suddenly they manifested these personality changes. I'd say that's not a personality disorder. Well, actually, you can diagnose it. But the cause is organic. Again, you're looking at the onset. You're looking at how long have they been abstinent. You need to be abstinent for quite a bit before you can diagnose a personality disorder. It can't just be a couple of weeks. You need to see somebody sober for, I would say, a few months. That's not always possible. You need to rule out, very basic, this is just basic stuff you do in any assessment. Have you had a head injury? Did you, a good example is, did you play football? Did you play an impact sport? They may say, oh, I've never had a brain injury. Oh, yeah, but I played football for 5 years. Really? You ever get your bell rung? You ever get knocked down, really knocked around a bit? Find those things out. Those are important. We are finding out a lot more about childhood injuries. Here's a discussion question for you, just backing up a bit. Can you make a diagnosis of antisocial personality disorder if the person has already been diagnosed with any of the following? An anxiety disorder, a histrionic personality disorder, or what if they've been diagnosed with anorexia? Can you make that diagnosis? And you ponder those answers. It's either no, yes, only for females, or only in children. And the basic answer there is yes. You can make a diagnosis of antisocial personality disorder with any of these other diagnoses. It is independent of those things. So, how do you treat these things? Well, relapse prevention. You've got to keep them sober. They need techniques to stay sober. The underlying characteristic of a personality disorder, the rigidness, is going to lead to difficulty being interpersonal with others. It's a personality disorder. They have difficulty connecting their personality to others. So you're going to have to work extra hard, especially in group therapy. You want to help them resist impulsivity and cravings. Basic defense mechanisms. We're going to go quick on this because you really should have a familiarity that basic defense mechanisms, denial, regression, projection, dissociation, etc., all of them generally interfere with a person growing and becoming a high-functioning adult. The one exception to that is sublimation, putting your energies into something acceptable. So you're angry and you decide to build a house. You're frustrated, so you write a symphony. That is sublimation. Very positive. Try to teach your clients how to move forward with how they feel. Therapeutic communities, we're going to kind of move quick on that because it's just not that common anymore. And it's not very effective with cluster B personalities. It's been used, but again, it's a therapeutic community, so it's the entire community behind it. Cognitive analytic therapy has been used effectively. Dialectic behavior therapy, you hear a lot about that, especially for borderline. A little bit more so now with other co-occurring substance abuse disorders. Dialectic behavior therapy is very effective. You need to be thoroughly trained in it and to understand it quite well in order to apply it. However, you can use some of the approaches of dialectic behavior therapy. For example, grounding techniques, getting the person to feel what they feel when they feel it in the moment with you. Schema-focused therapy, you would need to look it up to get thorough information on that. Not used all that often, but it combines elements of cognitive behavioral therapy with Gestalt. It's been found to be somewhat effective. The idea is that they have a dysfunctional self-image. So this schema focus is looking at early childhood experiences and helping them to reinterpret and revisit them and find better ways of handling things based on learning from the past and that you're giving them new ideas. Surprisingly, something as simple as fish oil supplements, omega-3s, have been found in a study to help women with borderline personality disorder. It seems to be well tolerated. It does seem to affect also manic depression. I'd like to see some follow-on studies. I'm simply giving you all the information as simply as we can of what is available. You're looking at how patients respond to personality disorders. The bottom line is that some evidence exists that antisocial and borderline people may have brain dysfunction. We need more data. Antidepressants and mood stabilizers, you use those to help them with their symptoms. It doesn't affect the underlying disorder. It helps them with the symptoms of the disorder. Psychosocial treatment, basically talk therapy and working in their environment, difficult. They do respond to talk therapy. They need to be stable in order to connect. And again, we're looking just at the cluster B components there. Dialectic behavior therapy, again, it is effective. What it requires is rather rigid. Individual therapy, group skills training. The client needs to be able to access their therapist between sessions. That means being on call almost 24/7. And you need a DBT consultation team to support the clinical therapist. That's more than most places or most people can put together. And so we use components of DBT. Developing skills, helping them to stay motivated, helping them to generalize those skills, teaching the clients how to restructure their environment to be effective for them. There are no current approved medications specifically for the disorders. You can't change a person's personality with a drug. It's one of their underlying characteristics. It's who they are. It's for somebody who's a computer person, that's their BIOS. That's the programming deep within them that doesn't technically change very easily or often. So again, antidepressants help with the depression. Mood stabilizers can be very effective when working with mood swings. Talk to psychiatrists, talk to MDs, people that you can liaison with. The antipsychotics are effective if they're having, again, psychotic episodes. They're sometimes used also as mood stabilizers or as antidepressants. There are some that are very effective. You really, really, really want to be careful with anti-anxiety medications. They are addictive. It's quite simple. A Xanax may help your client with their anxiety, his or her anxiety, but you're dealing with something that's highly addictive. And I've unfortunately seen that to be very problematic with many clients. Your choice as to how to work with a client who is using an anti-anxiety medication, it does help with the symptomology until they become addicted to it. Mentalization-based therapy, I'm only mentioning it because there is research, it's been found to work. It's psychodynamically oriented, so again, you're dealing with much more deeper psychology there. It has to do with attachment theory. You can look up NBT, see if it is of interest to you. The idea is that you want the person to stop what they're doing, to think about how they feel, and to tolerate the feel. You're looking at using it to build skills, interrelational skills, relationship skills, and it does seem to be somewhat effective for personality disorders. The other disorders, quite simply, there may be other diagnoses you can give a person. For example, they don't meet all the criteria. And that's the specified and unspecified personality disorders. Here are resources that you can look up. Easy to find on the internet. Very good resources. You're looking at National Institute of Mental Health, psychiatry.org. I like quite a bit. And just about any journals of psychiatry. Feel free to check in with me if you have questions. I can be reached at these addresses and phone number. More than happy to clarify anything that we've gone over. Understand these people are treatable. This is not something to run away from. You can help people with personality disorders. A little self-education makes a big difference. Good luck with that. Thank you.